I want to thank you all for this late Friday, and those were two fabulous talks. I hope that we can get them back. And I want to appreciate Dr. Volkmann. We have to meet. He's very brave to be the last speaker. And this will also be very interesting because I think that bariatric surgery is a way of prolonging and giving a better quality of life to a lot of people who are obese. And I don't think it's all lifestyle. I think there's a lot of that have to do with the brain. I'm a psychiatrist, but that's another roundtable discussion. Dr. Eric Volkmann is the director of the University of Utah Healthcare Bariatric Surgery Program at the University in Salt Lake City. Dr. Volkmann specializes in minimally invasive upper gastrointestinal procedures and bariatric, which is weight loss, surgery. Dr. Volkmann received his medical degree from the University of North Carolina School of Medicine. He then continued on his residency in Chicago at Northwestern Memorial Hospital, and while at Northwestern, he completed a 2-year research fellowship focusing on the development of new and minimally invasive surgical techniques. After finishing his surgical residency, he completed a clinical assistant professorship at The Ohio University, one of the oldest training programs in the country focused on minimally invasive surgery, where he gained extensive training in minimally invasive gastrointestinal and bariatric procedures such as laparoscopic gastric bypass, sleeve gastrectomy, and adjustable gastric banding. Dr. Volkmann's other areas of clinical expertise include diagnostic and interventional flexible upper endoscopy, laparoscopic surgery for complicated gastroesophageal reflux, GERD, hiatal hernias, achalasia, and abdominal wall hernias. And I'm almost through, so I'll give him his turn. And his research interests include surgical outcomes and quality and studying the effects of bariatric surgery on inflammation, nutrition, and gastroesophageal reflux disease. So, Dr. Volkmann, and let me just say hello. Pleased to meet you.
Nice to meet you. You're welcome. Well, thanks to all of you that stayed. I think bariatric surgery is a really interesting topic, and I promise I will make it worth your while for surgeons and medical doctors alike. Bariatric surgery is a growing problem in this country, and we're all going to be faced with taking care of bariatric patients, whether or not you are a bariatric surgeon. So today, the things I want to talk about, the first thing I want to talk about is obesity. What is obesity? I want to discuss its health effects and discuss some of the national trends that we're seeing in this country. Then I want to talk about the reasons for bariatric surgery, why you might consider it for your patients, and contraindications to bariatric surgery. I also want to talk about some of the different procedures that are out there and some of the differences between them. And then I want to talk about preoperative considerations. What do I think about when I'm selecting someone for surgery? And what are the complications that can happen after surgery? How do you identify them, and how do you manage them? So obesity is something I'm going to throw around a lot, but how do we define it? In strictly medical terms, we use BMI, which is a ratio of your height to your weight. Obesity starts at a body mass index of 30, which is considered class 1 obesity. Now, originally there were 4 classes of obesity, and if you see on that chart, we have exceeded class 4. And so we've had to come up with names with BMI greater than 60. Super or massively obese, and greater than 70, mega obese. And this kind of reflects what's happening in this country. If you look at what happened in the United States over a 10-year period between 1998 and 2008, the incidence of obesity increased by 50% in most states. Now, it's continuing to increase. You'll see Colorado there in 2008 is the lone blue state, less than 20%. They're no longer blue. Almost 1 in 4 individuals in Utah is obese. So even Utah, which is a more fit state, we still have an epidemic of obesity here. So when patients come to my office, there are 2 major reasons that they're interested in surgery. One is quality of life, and that's actually a very big one that we don't talk about a lot in the medical world. And the other is the effects on health. So I'm going to start with quality of life and common things that I hear. So patients say, I don't feel good. I feel tired all the time. Almost every patient who comes to see me complains of back, knee, hip pain. A lot of times they want to be able to participate in activities that they enjoy with their family, hiking, biking, skiing. They actually want to do these things, but they've gotten to the point where they're either so deconditioned that they can't or it hurts. They oftentimes have difficulty with activities of daily living or hygiene, cleaning up after a bowel movement, tying their shoes. They can't fit into seats in public places. As frustrating as it might be for you, sitting on an airplane when someone who's heavy sits down next to you, it's humiliating for them, and they don't like that. Patients face a lot of social stigma and discrimination, both in social circles and the workplace. And a lot of them just want to reduce the number of medications that they're on. What about the health risks? You're all familiar with the health risks. I mean, one of the biggest ones is type 2 diabetes, hypertension, hyperlipidemia, cardiovascular disease, and stroke. Osteoarthritis is a huge one. Obstructive sleep apnea, I would say probably 70–80% of the patients I see have obstructive sleep apnea walking in the door. Gallbladder disease, and a big one that people don't think about is cancer. Obesity affects almost every cancer risk for most cancers. It's really quite remarkable how many cancers it affects. And then there are increased complications of pregnancy. It's actually safer to have had a gastric bypass and once you're done losing weight rapidly, conceive and go through pregnancy than it is to be obese. Not to mention it reduces PCOS. It also can affect stress incontinence, improve stress incontinence and fecal incontinence. And then if you look at your chance of dying, when you compare someone who's obese to someone who's normal weight, and I'm not talking class 2 obesity where we start doing surgery, but class 1, there's a 50% to 100% all-cause increase in mortality. So being obese is not good for you. So who qualifies for surgery? Strictly speaking, we say patients with clinically severe obesity. What is that? That was defined by the NIH in 1991 on their consensus statement on gastrointestinal surgery for obesity. And now we're talking about a statement that's 20 years old. So if you think back to 1991, we were doing open gastric bypass surgery, and probably the biggest complications we saw of bariatric surgery were wound infections and hernias. We also didn't have people really specializing in it, people doing fellowships and learning how to do the surgery well and take care of patients. We also now have another 20 years of data on things like gastric bypass, which is pretty much our gold standard weight loss operation. But at that point in time, they said that the risks to patients' health outweigh the risks of surgery at a body mass index of 40, or when patients are about 100 pounds overweight, or 35 with any weight-related medical problem. Now, in all actuality, probably nowadays we could shift those numbers down about 5 BMI points, and there are studies looking at that, so that maybe someone with a BMI of 30 and type 2 diabetes might qualify for surgery. But if you're a general practitioner, these are the things to look for, and look for it. Weigh your patients and take their height, because I'll tell you, someone with a BMI of 35 is a lot thinner than you might think. When you actually start measuring these things, these patients, when people think of obesity, they think of really, really large patients, patients who actually probably have BMIs of 50 and 60. And there's a lot of people out there with BMIs of 35 and 40 that people don't think about. Now, one question I got when I came to the University of Utah is, well, weight loss surgery doesn't work. They just gain all the weight back. And you can. Weight loss surgery is a tool. Patients have to make it work for them, but it does work. It's the most durable form of weight loss that we have. And if you look at a systematic review of 22,000 patients, the surgery works. Most of the patients lose about 61% of their excess body weight. So if you look at what is excess body weight, that's your weight above your ideal body weight. So patients, they don't lose all their weight. They don't get down to their ideal body weight, but they get down to a healthy weight. And then if you look at excess weight loss by the type of bariatric procedure performed, or actually by their BMI class, with patients with regular morbid obesity, 71%. As you get into super obesity, less, 60%, but still good weight loss. And it does improve weight-related medical problems. This has been studied many times over. It improves or resolves diabetes, hyperlipidemia, hypertension, obstructive sleep apnea, a number of others. The list goes on. And what about diabetes? Probably most of you are familiar with the 2 randomized controlled trials that were published last spring. These showed that bariatric surgery is superior to medical therapy in the care of diabetes. The study from Dr. Schauer in Cleveland showed diabetes remission rates of over 37% for sleeve and even higher for type 2 diabetes versus medical therapy. This study actually was looking at obesity beginning at BMI of 30, so not even where we start considering bariatric surgery nowadays, which is a BMI of 35, where most insurers will cover it, including CMS. Another study from Italy came out around that same time, and they showed remission rates of 75%, looking at gastric bypass versus 0% for medical therapy. And I think the biggest thing is they started at a BMI of 35 in that study. And so what about your chance of dying? I think this is pretty remarkable. After bariatric surgery, your chance of dying from diabetic-related causes goes down by 92%. Cancer-related causes, 60%. Coronary artery causes, 56%. There's an increase in actually suicide and traumatic deaths, so that's why the overall rate goes down by 40%. Not everyone is a candidate for bariatric surgery, and I always say this at my information session. This is really for patients who understand what they're getting into and are able to commit to lifelong follow-up care. This is by no means an easy way out. Patients have to commit to it. But by the time someone comes into my office or comes to an information session, they've thought about it for a long time. The average patient's researched it for about 2 years, and they're really ready. They know that they're doing something drastic and dramatic, and they know that they need some help. And again, I talk about this as a tool for weight loss, and it really does require lifelong follow-up. If you have any bariatric patients in your clinic, they should be followed by a bariatric surgeon once a year, or at the minimum, you should know the types of things that need to be followed yearly in a bariatric patient. We'll talk a little bit about that. Just kind of expanding upon the fact this is not an easy way out. This is what an average patient who comes into my clinic has to go through. They all have to come to an information session because there's a lot of different surgical options out there, and I can talk to them for about an hour about all the different operations. So rather than doing that with every patient, we get them in a group and they can ask questions and they can do some research on their own. So when they come in, they're already informed about the operation and we can focus the interview on them. Then insurance verification. Unfortunately, a lot of insurers don't pay for bariatric surgery. It's kind of a shame, but they don't necessarily see the long-term benefits because patients change insurers. So insurers don't want to pay for surgery, and in some employers sign up for plans that don't have a bariatric coverage because it's cheaper, and that's unfortunate, I think, for a lot of patients. If patients don't have insurance coverage, we can put them through a self-pay program, but there's a lot of obstacles you have to consider there. What if a patient has a complication? Who pays for that? We actually had to sign up for procedure-specific insurance so patients aren't stuck with a big bill if something like that ever were to happen. We have patients complete a smoking policy. They have to commit to not smoking for 3 months before surgery and for life, and I'll talk about some of the problems with that later. We have them complete a sleep apnea screening form because general anesthesia in patients with sleep apnea is associated with increased risk of death, and they have to complete a 2-day food record. Then, once they've completed that, they come in for an initial appointment. At that appointment, they'll also see their dietitian, and we set them up for a psychological evaluation. All patients undergo pretty rigorous psychological testing because we want them to be successful, not just in the short term, but in the long term. They may also require additional medical workup, and oftentimes they'll need an endoscopy or an upper GI series beforehand. Then we put them into supervised medical weight loss for 3 to 6 months. Now, there's no evidence out there supporting medical weight loss before surgery, even though most insurers require it. But I do think it's very important to educate patients before surgery. Tell them how much fluid they need to drink, how much protein they need to eat, what types of vitamin supplementation they have to have, and see how they do in a minimum of 3 months. If their insurance requires 6 months, we put them through 6 months. And then they have a preoperative visit with me and an anesthesiologist if necessary. They then, once we schedule surgery, get an insurance pre-authorization. So it's a pretty long course. Now, 2 weeks before surgery, I put patients on a very low-calorie diet. A number of surgeons do this, and the main purpose is not to get them to lose a little bit of weight, but it's to actually shrink their liver. One of the first places they lose weight is from their liver and from their omentum, so they can lose about 15% of the volume of their liver. So contraindications to surgery. What patients do I think about when they come into a clinic? And I show this to patients. I say, if you're over 70, you may not actually reap a lot of benefits from weight loss surgery. At that point in time, probably the risks are outweighing the benefits. Adolescents are a gray area. A lot of their food choices may not be up to them. We don't know the long-term effects of weight loss surgery on these individuals. Smoking is an absolute contraindication. Not only does it increase perioperative risks, but patients who've had a gastric bypass, it puts them at very high risk for marginal ulcers. That's the #1 cause of marginal ulcers, followed by NSAID use. And if patients have chronic marginal ulcers, the treatment is not to revise the gastric jejunostomy, it's to take away the inciting factor. Alcohol or drug abuse makes sense. This is an operation we want long-term follow-up for, so if they're abusing those things, they're not going to be able to follow up. And non-ambulatory patients is a big red flag for me. If patients come in a motorized wheelchair, then I'm pretty sure they're not going to be able to ambulate early on after surgery to prevent DVT. Now, weight loss surgery is about as safe as having your gallbladder removed nowadays. Your chance of dying is less than 0.2%. But if there's something that can cause death after weight loss surgery, it's a pulmonary embolism. So we take DVT prophylaxis very seriously, and a big part of that is patients being able to walk. If they can't walk beforehand, I may put them into cardiac rehab to get them walking. And one gentleman, we put him into a weight loss program. He lost 50 pounds, got off his oxygen, and we did a surgery. 2 weeks later, he's now another 50 pounds down. But that was, I think, a good choice. We took a high-risk patient, converted him to a better-risk patient, and then allowed him to keep losing weight. Severe cardiac or pulmonary comorbidities, that makes sense. They're undergoing surgery. Organ failure or impending failure, in particular, I think about impending renal failure. We can put patients who have marginal kidney function into renal failure because they're not able to drink as much as we'd like, and that's always a struggle afterwards. Although some patients who are considering transplant and can't meet transplant criteria because of their weight, if we do a sleeve gastrectomy on them, we can have them reach that weight and we don't have to worry about ulcers with that operation. Inability to comply with nutritional requirements. This is one of the big things. We want to make sure that the dietitian and the psychologist feel that they can comply with long-term follow-up with that. Again, we want them to be successful. Now, mental illness is not a contraindication, but untreated mental illness is. So someone with bipolar disorder, for instance, we want to make sure that's under good control, and I'd have no hesitations operating on someone like that. So what are the surgical options that are out there? There are a number of them. There are two classes, malabsorptive and restrictive, and purely restrictive. So you're all familiar with malabsorptive and restrictive operations. That includes laparoscopic Roux-en-Y gastric bypass. That's still the most commonly performed weight loss operation in the United States the last time I checked. And then there's biliopancreatic diversion with duodenal switch, which has a little bit more weight loss, but is also very malabsorptive and causes a lot of GI distress. So that's probably why it's relatively infrequently done in this country, but we're seeing more of it. And then purely restrictive operations. You've all heard of the lap band, and then the newcomer, which is laparoscopic sleeve gastrectomy, which since CMS approved it for coverage about 3 years ago, we're seeing it covered by more and more insurers. So I'm going to go through these procedures one by one. The first one is gastric bypass. You can go ahead with the video. And then this is going to actually show you how we perform it. Just a picture of your gastrointestinal tract. We make a gastric pouch, just about 30 mLs, or about the size of an egg. And then we divide the small intestine about 40 centimeters distal to the ligament of trite, so bring up a 150 centimeter roux limb. And then you'll see at the end, it kind of forms a Y. So this is the roux limb here, and it forms a Y with what we call the biliopancreatic limb, and it forms a Roux-en-Y gastric bypass. What are we bypassing? We're bypassing that 150 centimeters of intestine. It's not seeing any pancreatic enzymes, so nothing's being absorbed in that roux limb. Another diagram of what we're talking about here. The opening from the stomach to the small intestine should be about 15 to 16 millimeters. So if you do an endoscopy and someone's complaining of dysphagia to meats and vegetables, you say, oh, I can drive the scope through, there's no problem. Patients can tell a few millimeters of difference, and I can tell you, from a lot of experience that dilating someone from 12 millimeters to 15 or 16 will improve their dysphagia dramatically. Now, when patients get strictures, the number one cause of strictures are ulcers, and I'll talk about that more, but NSAIDs and smoking. So if you take nothing else home from this, someone who's had a gastric bypass should not take NSAIDs of any sort or smoke for their life. And that's something I really drive home with patients, and if they can't comply with that, we don't offer them that particular operation. That being said, this is still the gold standard weight loss operation. This has been around since the 70s. We've had a lot of experience knowing how and where it can go wrong. As a result, in my practice, we rarely, if ever, need to reverse a gastric bypass. There's almost some reason somewhere that you can figure out what's going wrong and make someone feel better. This has the most weight loss of the operations that I perform. I don't do biliopancreatic diversion with duodenal switch. I just don't think the adverse effects of it are worthwhile. But patients lose about 60 to 80% of their excess body weight over about 12 to 18 months. What's great about this operation is it cures GERD. So the majority of the acid-producing cells in the stomach are in the distal stomach. So when we do a gastric bypass on someone with reflux, their reflux goes away. The other operations I'm going to talk about all can create reflux or make it worse. And actually, in patients with hiatal hernias with a body mass index of 35 or greater, where I'm worried about recurrence of their hiatal hernia because of their weight, we'll actually offer them, my partner and I, a gastric bypass with repair of their hiatal hernia. And we've had very good results with that, and that's what a lot of surgeons are doing throughout the country. Now, the effects on type 2 diabetes with this operation are independent of weight loss. So someone comes into the hospital and they're on oral medications for diabetes, they go home on none and their sugars are under good control. If they're on insulin, we send them home on half their dose, and their sugars, again, are normally under good control. We have them follow up with their primary care physician the following week to adjust things as necessary, have them check their blood sugars. But as they lose weight, that control continues to improve. This is the only operation where the effects are immediate amongst the ones I'm talking about. And it has to do with a lot of hormonal signaling pathways like GLP-1, which increases insulin secretion, and that goes up. Now, some of the drawbacks of the operation, and when you compare it to, say, gastric banding, which is totally reversible, this operation is difficult to reverse. I mean, we can put things back in the same arrangement where they were before, but there's no guarantee that things are going to work like they did before. The stomach may not work normally. If you convert, for instance, a bypass to a sleeve, that sleeve may not be functional. You may have injured the vagal nerve fibers, and they may get gastroparesis. Again, the risk of marginal ulcers, that's what I'm always thinking, is this person going to develop a marginal ulcer? That's kind of the bane of the operation, but with good patient selection, you can really minimize that. Now, because it is a malabsorptive operation, there's a higher risk of vitamin and mineral deficiencies. It seems to be a big problem in this part of the country. I didn't see this in Ohio, but I've seen 4 patients with severe thiamine deficiency and at least 2 or 3 patients with Wernicke-Korsakoff from this. And from just severe thiamine deficiency from having a bypass 20 plus years ago and not taking a multivitamin once a day. It's really a shame. They might have had a low thiamine, but they didn't have to have this if they were just taking a multivitamin once a day. Now, the recommendations for gastric bypass are a multivitamin twice a day, and calcium with vitamin D 3 times a day, and a B12 supplement. But a lot of patients are not taking the B12, but it's not the multivitamin. And if it's not twice a day, they can take a prenatal once a day. Now, dumping syndrome, when patients say, oh, I don't want to have dumping syndrome, but I actually think dumping syndrome may be a good thing, not necessarily a negative thing. For sweet eaters, it's a useful deterrent to keep them from eating sugary foods. If someone has a bypass and they're having a lot of diarrhea and gassiness, the first thing I'd want to check is, what's your diet like? We have to meet with our dietitian. We've had people, with problems for years, and just one meeting with the dietitian, we make them feel better because, we realize, drinking, a lot of soda in a day and eating candy and other things, it's going to do what it's supposed to do with this operation, which is make them feel uncomfortable. The next operation I'm going to talk about is laparoscopic adjustable gastric banding. You can go ahead and start the video for this one. Now, with this operation, we tunnel a band blindly behind the stomach and then suture it in place. Now, all these videos come from the lap band company. They were nice enough to share them with me, so they don't show anyone suturing the band in place and the port that's there. So this port has to be accessed with a needle, and we have to see patients once a month for the best results with this operation. And you can see we can fill the band, we can decompress the band, and when I first started doing this, everyone who came into my office wanted a band. And by the end of the visit, most people didn't want a band. And it's probably the same thing with the information sessions, but I don't get a lot of one-on-one with them. And there's a lot of reasons for that, and there's a reason why Allergan, which makes the lap band, has the company up for sale. But this is kind of what you'll see when a band's in place. You can see some of the gastric sutures. Let's see. Oh, well, there it is. Right up there. This is a type of the port that we use and the tubing coming all around from here. I'll talk more about this in a moment. But this is purely restrictive, so it creates a small pouch limiting food consumption. Now, we're just limiting it in one spot, so you're really walking a tightrope with this operation. You have to have the band just tight enough, but not too tight. If it's tight enough, then they're able to eat all food consistencies. They don't have problems with reflux or dysphagia, food getting stuck. If it's too tight, they get all of those symptoms, and it's pretty uncomfortable. And when it's properly adjusted, large pills may not go down. And I've run into this problem a lot with metformin. And generally speaking, people say any pill that's about the size of a Tic Tac or smaller goes down relatively easily. Now, with this operation, patients lose about 50% of their excess body weight loss by about 1.5 to 5 years. The goal weight loss that we look for is about 1 to 2 pounds a week or 4 to 8 pounds per month. Some of the best results occur with this operation when patients are seen monthly. So for people who live far away from me and can't come in monthly, that can be hard. I might suggest another operation, but it is labor intensive to get them to achieve good weight loss. Just like sleeve gastrectomy, resolution of type 2 diabetes tends to mirror weight loss. It is adjustable and reversible. Now, this operation may cause or worsen GERD. Same thing with sleeve gastrectomy. One of the things we think causes that is hiatal hernias. And I scope all of my patients before, not the bands, they get an upper GI series, but I look for hiatal hernias amongst other things. I probably would estimate that 30 to 50% of patients have some degree of a hiatal hernia. So if I see that, I'll go ahead and dissect out the hiatus at the time of the surgery and repair it. But I always confirm it with an upper GI series because I think that EGDs can overestimate it. Now, this operation can have a higher failure rate. Up to 25% of patients can fail to lose 30% of their excess body weight by 5 years. And more recent studies show that patients who've had a gastric band may have a reoperation of 40 to 60% or so when you look at them and you follow them out. That's for things such as gastric band slippage, gastric band erosion, device malfunction, or patient non-tolerance requiring removal. The last operation I'm going to talk about is sleeve gastrectomy. And we're seeing this being performed in larger and larger numbers. That's, I think, because it gives us kind of a middle ground between adjustable gastric banding and gastric bypass. It's a different operation. And the reason I offer all three is I tell patients there's not one right operation for everyone. For each person, there may be a different operation that's right for them. For instance, for gastric banding, great candidates for that operation, someone with a BMI between 35 and 40 who is motivated and working hard and just needs a little bit of help getting that extra weight off. Sleeve gastrectomy is deceptively simple looking. So you just fire a stapler up from the antrum up to the angle of His, and patients are going to lose weight. But I think that's the reason why the complication rate of gastric leaks is higher with this operation than with gastric bypass. Looking at international literature, the leak rate is anywhere from less than 1% up to 4%. And when I do a gastric bypass, the leak rate's about 0.25%. We haven't had any leaks with this, but some of that may be just understanding the physiology of this operation. And I'll talk a little bit more about that later where things can go wrong. Now, there are many good things with this operation. There's no malabsorption. The follow-up is similar to gastric bypass, not as intense as it is for adjustable gastric banding. Patients lose a fair amount of weight with this operation. It approaches gastric bypass about 50 to 70% excess body weight loss, and I think about 60 to 80 for bypass. Lower risk or almost no risk of ulcers when you compare it to gastric bypass. I don't worry about patients taking NSAIDs or taking steroids. I still don't want them to smoke, but if someone has rheumatoid arthritis or is going to need steroids for autoimmune disease or something else, I'd probably push them more towards, definitely for sure, more towards a sleeve than to a bypass. Again, I mentioned it's a newer procedure, so it's not covered by everyone. And this operation, again, may cause or worsen GERD. Up to 12% of patients afterwards can have GERD. In patients who already have GERD, I wouldn't do this operation if they have Barrett's esophagus, because we can make their GERD worse. Not only that, we've taken out the greater curve, which is used when we make a neoesophagus and with the gastric conduit. So not probably a good thing to do in someone with Barrett's. Now, staple line leaks, as I mentioned, are more common, and they're more difficult to manage with this. I'll talk more about that later. And then we don't know the long-term data with us. We have really good 5-year data that shows this is a good operation, but we certainly don't have great data going out to 10, 20 years. Some other bariatric procedures that I've either talked about or you may see are biliopancreatic diversion with duodenal switch. And biliopancreatic diversion with duodenal switch is how sleeve gastrectomy came to be. We used it as a first-stage operation to get patients to lose weight and also see how compliant are they going to be with follow-up. Because, as I mentioned, patients can get bloating, flatulence, severe fat-soluble vitamin deficiency, A, D, E, and K. And then another operation which used to be done, which isn't done anymore, is vertical banded gastroplasty. And with this operation, we'd punch a hole with a circular stapler and then fire a non-cutting TA stapler up to the angle of His. Problems with this operation is this area can open up, but a bigger problem is we put a polypropylene band here. Now, over time, that gets pretty severe stenosis and stricture. Most of the time, it's not responsive to dilation, although I'll try it first. But you can see this looks like a gastric pouch. Oops. This looks like a gastric pouch here in a bypass. So this is easily converted by just transecting across here to a gastric bypass. But you won't see this very often, but if you're doing endoscopy or taking care of patients, I saw someone who was referred to me today who I think has this problem, and if you recognize it, it no longer becomes such a black box. Bariatric surgery can have perioperative complications, just like any operation. We'll talk a little bit about those. Bleeding infections common with any operation. Incisional pain. This is something that's kind of interesting. Patients come in, they're getting a weight loss operation. Some of them may have never had any surgery before, and all of a sudden they realize, wow, surgery hurts. So I always try to tell them this is really a real operation. You can count on 2 to 3 weeks of downtime from work, and you may not feel yourself for about 3 months. Patients really don't turn the corner and say, hey, I feel great, I'm so happy I did this, until they hit about 3 months. DVT and pulmonary embolism, that can happen in under 0.5% of patients. And anastomotic and staple line leaks occur, but not, I think bariatric surgery really gave itself a bad name in the early 2000s. I think there are a lot of people doing it who probably, maybe shouldn't have been doing it or didn't have a lot of training, didn't prophylax appropriately for DVT and PE, and there were a lot more leaks and a lot of deaths. And I think as a community, we've done a great job coming back from that, but that kind of flavor is left in a lot of people's mouths. And as I mentioned, chance of dying from this operation nowadays is less than 0.2%. It's about as safe as having your gallbladder removed. Now, anastomotic leaks, when I think about the bad things that can happen. Gastric bypass, less than 0.25%. Sleeve gastrectomy about 1 to 4%. And we think about this as kind of a high pressure system. So there's a potential narrowing at the incisura angularis. I'll show that to you. Go back a few slides here. But that is right here. If you fire a stapler too close this way rather than this way, you're going to get narrowing. That often results in either blowout of the gastric fundus if you leave some behind, which we don't want to have happen, but I've seen it, and leaks right there. The other thing that causes it to be a higher pressure system is there's a pylorus in place that has to relax to let food go through. So I normally leave patients on a liquid diet for about 4 weeks instead of 2 weeks compared to my other operations. Now, early leaks can occur in under 2 weeks after one of the operations. Late leaks occur after 2 weeks, and those are pretty uncommon in gastric bypass, but they're not at all uncommon after sleeve gastrectomy. When you look at when they get leaks, where do they occur? When do they occur? If you work in an emergency department, things that you might see with patients in a leak, or if you're taking care is tachycardia. That's the most sensitive finding. And I tell my residents, if their heart rate is sustained in the 110 to 120 range and doesn't move, you need to have an increased suspicion for leak. Now, that doesn't mean that I rush that patient to the operating room. We make sure that they're well hydrated, that they're not bleeding. If they need to go to the operating room, then I tell everyone the day of surgery, if something doesn't look right, we may take you back and just put all the ports back in the same place. And if 75% of the time we don't find anything, I'm satisfied with that. But we rarely have to do that. Other signs, you take the whole patient picture together. So we look fever, pulmonary complications are actually relatively common when they have this. Leukocytosis, abdominal pain, nausea. Pain away from the incisions for me is kind of a warning sign. They should be hurting at their laparoscopic incisions. If they're not hurting, by those and they're hurting elsewhere in the epigastrium, that makes me uncomfortable. So just talking to a patient can help you work this up. And generally speaking, CT is a little bit more sensitive than an upper GI series. You get more information. You're not just looking for a leak, but you can see an abscess, you can see inflammation, you can see the jejunogegenostomy, you can see a number of other things that may be causing it. As long as we're scanning the abdomen, I'll go ahead and scan the chest. Now, how do we manage these? With the gastric bypass, actually where I trained at Ohio State, they published something on just gram patching and drainage. And that works. You gram patch it, drain it, maybe just hold off on feeding for several days or give them enteral feeding access, and these all heal. And the most common cause for, not just a leak, but we're talking perforation actually. For a perforation would be smoking and NSAID use, but early on a leak, you manage it the same way. Sleeve gastrectomy is a little different. Because it's a high pressure system, just throwing some drains in there and trying to gram patch it, it's not gonna work. You have to put an esophagogastric stent in. And these are stents that are about 15 centimeters long, 150 millimeters. And you want to make sure that you have good esophageal purchase, but also that distal end of the stent should go beyond the incisura angularis. If you don't, there's still going to be that narrowing there and things can backflow. And when I place a stent that way, these generally will heal. But you want to get to them early while they still have a chance of healing. And I talked about considering enteral feeding access. It's not always necessary, but sometimes if you don't get it, you'll wish you had later on. So long-term risks, anytime any patients are losing weight rapidly, whether it's with surgery or medical weight loss, they can get gallstones. We try to prevent this with Actigol. We don't routinely take out gallbladders and subject patients to risk of common bile duct injury and other related complications. And we do this while they're losing weight rapidly. And I've gone in and taken out gallbladders on many patients who've had bariatric surgery. It doesn't really complicate the operation, although oftentimes surgeons are uncomfortable with it. So I don't really think that there's an indication to take it out beforehand, but we want to try and prevent patients from getting gallstones if possible. Now, a big thing that I talk to patients about is that they may have difficulty adjusting to their body image. They may get excess skin on their arms, their hips, and their abdomen, and it's just, oh, I'll be okay with that. But you get out to a year, and it does start to bother these patients. And especially if they're working really hard, and they're exercising, they're going to the gym, and they're getting fit and healthy, and they just can't get that last bit off. And having that skin removed with plastic surgery often is not covered by insurers. It's considered cosmetic. The only way they'll pay for something like a paniculectomy is if patients are having medical problems, back pain, interfering with ambulation, they get a rash maybe under that area where it's moist. The risk of ulcers and strictures, you may need an endoscopy to dilate this. And again, gastric bypass, no NSAIDs, steroids, or smoking. That's not just before surgery, that's for life. You can get internal hernias too. I'll talk about that more later, but I got a call from Idaho when I first came here, and they sat on a bowel obstruction, didn't look that concerning, no dilated loops. Patient's abdomen wasn't that tender. Kind of what you'd expect with an internal hernia. And what happens in an internal hernia is most of the bowel rotates through. All the bowel beyond the jejunostomy died. And that person will probably have short gut. So this is one of those things you don't want to miss. If someone's only had a laparoscopic gastric bypass and they have intra-abdominal adhesions, you have to be thinking about that. Gastric bands can have their own complications, slippage, erosion, infection, malfunction. I'm going to talk about a lot of these later. So I'm going to start out with just talking about ulcers, strictures, reflux, and pain. So ulcers and stomal stenosis after gastric bypass can occur in about 4 to 5% of gastric bypass patients. This can be normal in the perioperative healing phase, so we prevent this by sending patients out on a PPI. I do it for 2 months. Some places do it for up to a year. Late phase, it's almost always by doing one of those things I talked about. Now, how do these present? Ulcers generally present with constant epigastric pain. Patients will say it's there all the time. They may have some nausea, it may be worse when they're drinking. Easily diagnosed with an EGD. The ulcers tend to be on the jejunal side of the gastrojejunostomy. And other things that can cause them is a gastric fistula. It's normally at the top of the stomach, maybe where the staple line wasn't completely divided. That leads to increased acid levels within the pouch that can make them more prone to getting an ulcer. When I see these, I treat them with a high-dose BID PPI and sucralfate suspension QID, and then removal of the inciting agents. And that almost always will make the ulcers heal. And if in the event of perforation, I really worked a lot with our surgeons saying, please, please, do not take down the gastrojejunostomy. Just gram patch it and drain it and treat whatever's causing it, and it will get better. The stomach is very hardy. Now, strictures are a little different, and there's some nuances to, is it a stricture or is it an ulcer? Now, these patients, they'll get postprandial epigastric pain, most commonly with solids, meats, breads, raw vegetables, and fruits, and then it goes away. They don't have pain all the time, but it's related to foods and probably don't have much of a problem when they're drinking, but with solid foods, they do. These are pretty easily treated with serial endoscopic dilation. I normally dilate them up with a through-the-scope balloon, and I try to get it up as close as I can to 15 millimeters, but I stop when I start to see some bleeding. And then we'll bring them back. Normally we'll need 2 or 3 dilations to keep it open, but if it's a pretty small stenosis, and some patients come in, they've got a 3-millimeter stenosis, but if it's 12, maybe just 1 will be all they need. Now, you can also get narrowing after sleeve gastrectomy, and these can respond to dilation, but not quite as well as a bypassing. You often have to go up to like a 20 millimeter balloon to try and stretch it a little bit. And sometimes it's an angulation, and it's a difficult problem if they get this after a sleeve gastrectomy. And I talked about strictures after vertical banded gastroplasty and converting that to a bypass. So GERD, this can happen after gastric banding and sleeve gastrectomy. With sleeve gastrectomy, you always want to look at, is there some kind of distal obstruction that can be causing it, a hiatal hernia, which hopefully was addressed at the first operation. With adjustable gastric banding, sometimes GERD is a symptom that the band is just too tight, but we really want to look for hiatal hernias and try to repair them at the time of the operation to prevent this. Postoperative pain. That's one thing. I'm sure one day I will have someone in my practice, since it's still a relatively new practice, who has postprandial or just abdominal pain, but I think the best way to avoid a bariatric surgical patient with Postoperative pain is to be sensitive to patients having preoperative pain. Once you operate on someone with abdominal symptoms, someone maybe who has, irritable bowel syndrome, once you do a bypass on them, people will attribute that to their surgery forever, no matter what. They won't look for other causes, maybe, but most often people will say it's the bypass's fault. So when patients are having gastrointestinal complaints before surgery, I will try to avoid doing a bypass on them. And I know for people who are doing them on transplant patients, bypass has problems with patients who need steroids. They can get ulcers, but also patients who've had transplants get a lot of infectious diarrhea. And people think, oh, well, bypass is a malabsorptive operation. But most of the time when patients have had a bypass, they tend to get more constipation than they do diarrhea because they're not able to drink enough water. But I try to select, patients who they're not going to attribute things to their operation. Other things that can cause pain, not just strictures at the gastrojejunectomy, but also at the jejunojejunectomy. I've seen a number of patients who have a bowel obstruction there. There's a lot of staple lines there, and they can actually get adhesions right at that area. Sometimes I can get down there with the endoscope and we can see angulation. You can see a dilated roux limb on CT scan. So CT can help, endoscopy, upper GI series, whatever you can do to look at that area. Internal hernia, that's what I was talking about. Now, internal hernias tend to occur through the mesentery of the bowel. There's a few places they can occur. For retrocolic roux limbs, and a lot of people who are doing them laparoscopically do anticolic, but you can get an internal hernia through the transverse colon mesentery. Probably don't see that as much. You can also get them through Peterson's space, which is where the roux limb mesentery kind of abuts the transverse colon mesentery. But the most common place we see it is at the jejunojejunectomy, or the small bowel anastomosis. That was probably more common in the 2000s before people were routinely closing it. And even with closure, it can still happen if it's not closed posteriorly enough. These patients will generally present with intermittent, crampy, right upper quadrant pain. The bowel most commonly tends to herniate from left to right, but it can occur right to left. And what you'll see on a CAT scan is when you look in the coronal images, you'll see swirling of the mesentery, showing that the bowel's rotated through. You may see a mass of decompressed bowel on one side of the abdomen and a paucity of bowel on the other side of the abdomen. And this is really a surgical emergency. This is not something you want to sit on because it can cause ischemia and can lead to rapid bowel death. So in patients who have a bowel obstruction and haven't had open surgery, which is still the most common cause of adhesions in this country, if they have had a laparoscopic operation, laparoscopic gastric bypass, a bowel obstruction, this is something I always want to rule out and go to the top of the list. So dysphagia following laparoscopic adjustable gastric banding. A good clinical history is really important. If a patient comes out, I've got dysphagia, and they got their band filled the other day, well, it's probably people put a little too much fluid in the band. If their band has been properly adjusted, they're out several years and it's been fine, and all of a sudden they can't swallow, then I'd be thinking more about other things that can cause dysphagia, like an adjustable gastric band slip. Signs of an over-tightened band can be dysphagia to solid foods, similar to a stricture in a gastric bypass or GERD symptoms. That might mean we have to take a little bit of fluid out of there. If you ever need to decompress a band, you want to make sure you do it with a Huber needle, not just an 18-gauge needle. You'll core out the port and ruin it. And if you're going to take fluid out, make sure you document how much is in there. If you take out 8 cc's of fluid and no one knows how much you took out, it's going to be difficult to figure it out until the first adjustment, but it's helpful to know how much is taken out. Now, bands that are chronically overtight, you can see esophageal dilation, pouch dilation, and I've seen patients come to me with this, and people have tried to endoscopically dilate it. It's a balloon. You can try and stretch it all you want. It's going to go back to the same position. Band slippage. This is, one of the big reasons for need for reoperation. Generally, these patients will have acute onset, difficulty swallowing, pain. If this happens acutely, this is a surgical urgency. The first thing you want to do is decompress the band completely and then try to get them to the operating room as soon as possible to either revise or remove the band. And in my practice, I probably do more revisions and removals than I do actual placements. Band erosion. Now, the important thing to take away from band erosion is if you ever see someone with a port site infection, there's inflammation around the port. The most common cause of a port infection is not contamination with a needle oxygen, it's band erosion. So a patient who has a port infection, you have to rule out band erosion. If you go ahead and replace the port, they're still going to have an eroded band, and probably the port will get infected again later on. Band erosion. Now, the important thing to take away from band erosion is if you ever see someone with a port site infection, there's inflammation around the port. The most common cause of a port infection is not contamination with a needle oxygen, it's band erosion. So a patient who has a port infection, you have to rule out band erosion. If you go ahead and replace the port, they're still going to have an eroded band and probably the port will get infected again later on. So what does a band slip look like? The normal orientation of adjustable gastric band is about a 45-degree angle up to the right shoulder. It travels from the base of the right cruciate of the diaphragm up to the angle of His. And our radiologists, when we started doing this here and started seeing patients, they didn't realize that it's a very small bit of the stomach. It's just the smallest bit of gastric cardia above the stomach. And the way food passes down through the band is actually by esophageal peristalsis. So those are pictures there of properly looking, proper band orientation and a normal looking pouch. Now, what does a band slip look like? Normally, you get horizontal position of the band. So you can see the band has gone from being at that 45-degree angle up to the left shoulder to a more horizontal position. You can sometimes see in the lumen of the band, which you shouldn't be able to do. And you can see, it looks like there's some stomach above there. That's not normal looking. That's a band slip. Now, this is kind of my soapbox, which is vitamin and mineral deficiencies, because I see so many patients who haven't had proper follow-up and haven't been taking their vitamins appropriately. So the next slide will kind of talk about what patients who've had bariatric surgery should be taking for vitamins. But the most common thing we see is vitamin D deficiency. We see that in people before surgery when we check their labs. And severe vitamin D deficiency, they'll generally present with a normal calcium level, low vitamin D, and elevated PTH level, which is not good. It means they're eating their bones to maintain their calcium levels. Protein malnutrition can happen, and after surgery, patients need at least 60 grams of protein a day. They really need to weight their meals heavily towards protein intake. If you see someone who's had weight loss surgery and they're losing their hair, their nails are brittle, and they're getting muscle atrophy, if you check a prealbumin level on them, it's probably going to be low. Iron deficiency anemia can occur. Most people who get bariatric surgery in this country are females, and they're younger females, so they may be of reproductive age. They're the most likely ones to get iron deficiency, so we screen for that. Thiamine deficiency, again, I would say this is probably one of the more common things we see, and you want to check this with whole blood, not a serum level, because serum levels may not reflect accurately their true level and may be falsely low. Folate can be something else they can become deficient in. B12, they don't absorb B12 well. Zinc deficiency. Now, patients can absorb B12, okay? So they don't necessarily have to have shots, but they may need either sublingual, where it gets directly absorbed into the bloodstream, or high-dose oral crystalline B12. Zinc deficiency can happen, vitamin A, vitamin K, and I've seen people who've had everything abnormal. When they get zinc deficient and severe protein deficiency, they can become immunosuppressed, and candidal esophagitis, you name it. And it's really a problem, something that can be easily fixed with routine follow-up with someone who knows for what to check for and make sure that patients are on what they should be on. So for a gastric bypass, again, that's a multivitamin twice a day, or a prenatal vitamin once a day, calcium with vitamin D 3 times a day, and a B12 supplement. For biliopancreatic diversion duodenal switch, they don't need B12 because they still have the antrum of their stomach, but they do need vitamins, fat-soluble vitamins, because they have a hard time absorbing those things. I treat adjustable gastric banding and sleeve gastrectomy the same, which means they take a multivitamin once a day instead of twice a day, same calcium with vitamin D requirement, and they don't need B12. So that's going to conclude my talk here, and hopefully what you'll take home from this is that the prevalence of bariatric surgery is increasing. We've really created this population of patients that many people didn't take care of while they're training and may not know kind of what's happening with the procedure, but you need to see it, because we're all going to see it. And I think that's one of the best things about bringing bariatric surgery to the U is that we're training residents now who may go into practice and realize how to recognize and take care of bariatric surgical complications. And the recognition of them requires understanding of what's happened in the surgery and where things can go wrong. Overall, though, this is a safe surgery, and it can really improve patients' quality of life. My favorite part of what I do is my postoperative clinic and seeing patients happy and healthy and doing better. It's just, there are very few surgical specialties where you get that, and it's really wonderful. Please take home that people who are candidates for bariatric surgery have a body mass index of 40 or greater, or 35, and a weight-related medical problem. And think about the fact that the pre- and postoperative evaluation of bariatric patients requires consideration of the type of procedure they're having, and all these patients need to follow up with a bariatric surgeon for life, or someone who is used to taking care of those patients. Thank you. You have a question?
Just a quick question. I don't know how this fits in, but do you screen for Helicobacter pylori before, or does it cause complications post-operative?
It can, and we've actually seen ulceration in the gastric remnant too, which makes me concerned. So we draw a large battery of tests, and H. pylori is included in that. We normally draw the labs right after the preoperative visit so we can correct any nutritional abnormalities before surgery. If their H. pylori serologies are positive, then I biopsy them and see if they in fact have it. If not, then if their serologies are negative, I don't biopsy them. Yes?
Yeah, two questions. Do you have an age cutoff for adolescents that on the lower end that you would not do? What do you, in your opinion about adolescents and teenagers and young people?
Yeah, I don't do adolescents. If they're 18 or older, I'll go ahead and do the surgery. When it gets down to younger ages, there's a lot of places that are trying. It's still kind of a gray area. They are children. They may not have fully developed all of their eating habits. Some of them may be controlled by their parents. And we haven't looked at the lifelong outcome of someone who's had a bariatric procedure. So, some of the earlier ones, when people started doing it, were in adjustable gastric bands. I've definitely heard advertisements in the Salt Lake area for some places that are doing adolescents. And it's not something that I'm doing now, but it may be, our population is getting larger, and you see it in children. And so, I have a feeling that in the future we're going to be seeing more bariatric surgery in adolescents. So I know that doesn't really answer your question, but I don't do it in children right now.
Just two questions. How effective is a gastric sleeve in treating something like gastroparesis? I know I have a few friends back east that are starting to do some studies on this now, and I didn't know if you had any data on that.
Well, we think it increases gastric emptying time. So there are some surgeons who recommend sleeve gastrectomy for gastroparesis. But for me, I'd probably prefer to do a gastric bypass in them. And that's gonna, they're gonna have a small gastric pouch that empties into the small bowel. And patients I've had with gastroparesis, we've done this on, have been very satisfied.
And second question, how much of a complication rate is it to damage like the vagal nerve with the banding? Is that at all something that you see?
I haven't seen that. My partner I work with always wants to preserve the vagus when we're doing a bypass, and I do it to appease him and come in perigastric, but we used to routinely come right through it with a stapler, and I know that I believe at the MGH, they looked at division of the vagus versus preserving the vagus after gastric bypass. It made no difference. Where it might make a difference, though, is if you injure the vagus and you rehook up a gastric bypass. That makes me uncomfortable putting the stomach back together. I worry about gastroparesis, and I've definitely taken care of a patient who had a gastric bypass and had an autoimmune cardiomyopathy and put her on steroids, and she got chronic ulcers, so they reversed it to a sleeve, and her stomach doesn't work. So I think really choosing the right operation the first time around is probably the most important thing. But I don't worry too much about gastroparesis and adjustable gastric banding.
If someone is on the proper supplementation, do you still recommend annual laboratory testing?
I would. Patients oftentimes don't take their supplements as they're supposed to, and when we get their labs back, it comes back. Now, I think, the labs that need to be checked are well published. You can find guidelines on the ASMBS's website, and you can find them readily. So, I would love to see more, practitioners in primary care knowing what to check for and checking it, but what I see right now at the university is a lot of practitioners check some things, but not everything. I think a great product that's out there is called Bariatric Fusion. I have nothing to disclose with them, but it's like a chewable multivitamin, and they take it either 3 or 4 times a day. And our patients who take it generally have better compliance with it because it's just easy to take, and it has higher levels of iron, B12, and thiamine. And when they're taking that regularly, their labs are normally pretty perfect. But any patient who's doing what they're supposed to do, their labs come back normal. Really, the problem is in inadequate preoperative education or patient non-compliance. And if patients are taking, I tell them, I don't care what you take as long as you're taking something that we recommend. And there are lots of different potential things that they could be taking out there. A great multivitamin is a Flintstones complete multivitamin. Take that twice a day. It works great. but they have to be taking something, and someone has to be checking for it. And the problem is a lot of people don't think about it, and they don't check for it, and they get problems. And it's very frustrating for me to see that, because these are totally preventable problems. Thank you all for sticking around for your time.